Okay, so today is Tuesday, October 27th, 2020. So one of the things that I've noticed in a lot of books that include treatments, most people, with the exception of Legge and even that a little bit, have a pretty narrow range of treatments that they apply to different conditions. And the back is more than really any other area is very complicated because there could be so many different things going on, as illustrated in just the common back conditions that I included in the last class's notes and then also at the end of today's class notes, which is back strains, muscle strains, back sprains, herniated discs with or without sciatica, um, and there's so many other little sort of like mini injuries that can go on with strains of the ligaments that attach to the posterior superior iliac spine, the PSIS, piriformis muscle problems, the ligaments that attach to the ischial tuberosity, all the SI joint issues that can be going on that are either ligamentous or muscular, and then the whole sort of overarching range of like B syndromes. What is the name of the documents I'm referring to? So under Module 9, they should be the first two documents.
Okay, so guidelines for treatment and corrective exercises. Okay, thank you. Thank you.
And so there's so many different things going on, and I read different texts about like how to treat this or that, and what I'm hoping to do is not overwhelm you with treatment choices, but to say, these are the things that you can choose from based on your assessments, right? So those are dots that are not hard to connect given what I'm teaching you in terms of how to assess your patients, starting from what makes them better, what makes them worse, going through that list on the assessment and diagnosis essay about, is it relatively more chi than blood phenomena? Is it relatively more excess than deficient phenomena, right? And going through that list, right, checking the sinew meridians, checking the primary meridians, doing like a visceral assessment, 8 principle assessment, hot, cold, exterior, so on. And then looking at muscle tests, right, and orthopedic evaluations, right? These are all things that are going to give you a really complete understanding of what's going on. And even then, it can sometimes be a little bit mysterious, and also considering other factors like the patient's age, the patient's weight, their, how they eat, what kind of rest they get, all the normal stuff. And, what's the nature of their spirit, right? Which we don't need to go into a lot because you guys have had a fair amount of discussion and introduction and training of that in other courses. But, how do you assess their stories, their relationships to their issues, right? So these are all the things that I wanted to give you. And even though you see this like long list of treatments, broken up into like yellow highlighted treatments and blue highlighted treatments and green highlighted treatments for primary, secondary, tertiary things to consider. Once you go through the assessment process, these treatments are going to make sense, right? Like why you would do one versus another, even though they're in that same primary group, right? Because these are the ones that I think are like the most go-to, but like obviously I put sinew meridians first. But if obviously if the sinew meridians don't test positive, I'm not going to be treating the sinew meridians, right? Okay. All right. So let's go over some treatment guidelines. So I'm going to start on page 9. I didn't edit the first page very well. I did include a recap of that, right? The image with the reviewing the postural assessment. I can't tell you how big a difference doing the postural assessment has made in my practice in the treatment of just about everything. Even people come in with neck pain and I correct the imbalances of the hip and low back. and a lot of that either eases up or disappears. What I have included in this one is, if you look through the orthopedic exams, and we'll go over this in a bit, at the bottom for each section, the anterior pelvic tilt, the posterior pelvic tilt. Uh-oh, is this? Oh, that's funny. I think I kept it like on the short edge. So when I did it double-sided, it did it kind of funky. All right, but hopefully you'll be able to get it. At the bottom of each section for anterior pelvic tilt, posterior pelvic tilt, elevated ilium, and pelvic rotations, I'm giving you some like special secret treatments that I got from Matt Callison.
Is gallbladder 39.5 halfway between 39 and 40?
Now you got it. Excellent.
Okay.
So when I say points like, you know, small intestine 3.75, that's 3/4 of the way between small intestine 3 and small intestine 4. Right? Okay. So, you know, like lingu would be technically like large intestine 4.25, because it's about 1/4 of the way to large intestine 5. So that's just a way I use to document in my treatment sheet. So, you know, if I have to look back at my chart, or if I'm documenting it for somebody else who's maybe covering my practice, they can see, you know, what I've been doing. All right. So what I would ask is that you please don't share that material, that single line of treatments. That's something that I learned from Matt Callison. And I know he's pretty protective of his material. So one, I'm not forwarding this to you, you know, as if it were my own, because it's not. And also I'm just forwarding it to you because it can start a larger conversation about how we relate, how certain points relate to the sinews of the liver and the gallbladder, which have a lot of control over the postural assessments. I'm not going to go into those points right now, but these are some point combinations that you can do first when you discover these postural imbalances. All right.
Hey,
So,
time.
yes.
This set of notes should be about 4 pages long.
Yes.
Okay. Thank you.
What I've also included, I believe, is a postural assessment and treatment page like this. It's two-sided. It should be titled Postural Assessment and Treatment. And it's a little grid that I made up the other night for you guys to kind of give you a sense, like just sort of an overall sense of like, okay, when you've got these postural imbalances, these are the muscles that are involved. Is that not on the?
I don't see that one time.
I may not have published it, so I will email that to you. Let me see.
I think it's closer to the bottom. It says PT, orthopedic evaluations.
No, the orthopedic evaluations is a PowerPoint.
Yeah. Okay, yeah, I think I just didn't put this on here. I will email that to you. All right. Yeah. Okay. Yes, I will email that to you. That's right, because I didn't want to publish it onto the Canvas site. So I will email that to you at the first break. All right. So basically, let me go over the treatment guidelines. So I will email this to you, and then we'll cover this when we talk about the hip. All right. All right. So for treatment, I still use a 1 to 10 treatment scale, like pain scale. Some people, like, you know, they find it a little bit irritating. They don't like it. It's kind of annoying. And also just about like every doctor or PT they've ever gone to has used the same scale. So some people get a little bit tired of it, but I find it very effective. I consider 8 through 10 out of 10 pain very severe. So if people say, oh, 10 out of 10, I'm like, So you basically, it's severely nagging you or bothering you to the point where you're not able to pay much attention to anything else, and you're kind of, you know, writhing around in pain. That's kind of 10 out of 10, right? So 8 out of 10, 9 out of 10, 10 out of 10. Generally, I want to see that patient 2 to 3 times a week. I consider moderate pain anywhere from 6 to 8 out of 10, or 5 to 5, 6, 7 out of 10. And I would want to see those people generally about twice a week. And then 1 to 4 out of 10 is mild or minor. And I'd like, you know, see those people about once a week. That's a general guideline that works for me. This is something that I came up with for me in my practice. You know, feel free to do how you do. I'm just giving you a sense. And then this is something that I can, you know, use to communicate with my patients about prognosis and treatment planning, because the more you involve your patient in understanding why you're asking them to come see you at a certain frequency, based on things that they report, not stuff that just you've come up with, because some people are untrustworthy and they're like, oh, he's just, you know, making this stuff up to give me a reason to come in for a lot, you know, so he can get rich. And there are a lot of patients out there who have that attitude. And there are also a lot of patients out there who don't have a lot of, what's that word, that type of income, like where they can afford to, you know, experiment with acupuncture, right? They don't have a lot of extra income to play around with. Disposable, thank you. Right. So,
Yep.
so, you know, I do modify if they don't have insurance, I do modify my fees a little bit to make life a little bit easier for them. I know some people don't, but I do. But that's basically, you know, how I decide, you know, how frequently I want to treat my patients. You know, treatment is always based on whatever phenomena or test provokes the most significant pain or discomfort, right? And that's generally what I start treating first. If a patient's in a lot of severe pain, generally they're not going to be able to focus a lot on what's going on with them or the world around them, and they're not going to it's going to be hard for them to make clear decisions. So I try and relieve as much pain as possible in the first visit, especially if it's like an 8, 9, or 10 out of 10 pain. Okay. So, you know, whatever I test with that creates the most discomfort, whether that's a sinew meridian test or a primary meridian test or an orthopedic evaluation, that's what I address first, right? If they are not in 8, 9, or 10 out of 10 pain, and I suspect they are possessed, I will treat possession first. Now, JR said that if a person's possessed, treatments won't hold over a period of time. But if they're in a lot of severe pain, I'm not worried about how long the treatment holds. If I can get them, you know, down off of that ledge, you know, for a few days, that's going to make a world of difference in their life and the life of the people that they interact with. I once treated this guy. He was like the second person in charge of this very large company organization that had like thousands of employees, and he was in charge of a lot of people, and he was in 10 out of 10 sciatic pain. He was like taking like oxycodone like 3-4 times a day, and it was like barely touching the pain. He couldn't sleep, and he was like, he said it made him a total SOB. And he was like a really large guy with a very deep voice and British. It was a very imposing figure. So, you know, him plus that in a bad mood, I mean, he scared the shit out of people, frankly. And I know this because after I treated him and helped him, the president then came in, and then like about a dozen of his employees came in because they were like, I don't know what you did with him, but oh my God, he's like a totally different human being. So, you know, and he was possessed, but I really wanted to treat the pain, you know, help relieve some of the pain first, because that, you know, that's like the superior physician. It treats society, right? So it treats the relationships. So, if I can get them down off of that, then I can, then they're present enough. I can treat them with the IDs and the AE or EDs and AE and so forth. Okay. So that brings us to kind of like this root branch concept, right? So root treatments obviously treat the underlying, what we think is like the factors that were primarily involved in leading to the development of this malfunction, right? And therefore the symptoms. So, in Worsley, that's the CF. In the TCM world, that's the pattern of disharmony. This is going to include spirit level imbalances. It's going to include mental level blocks, how they think, stories they're caught in, internal pathogenic factors, right? Emotional causes of disease, Zongfu organ patterns, and even miscellaneous causes of disease, exposure to electricity, trauma, which I consider to be like an external cause of disease. But all these things can be, the sort of the root, the thing that like the imbalance that, started off this malfunction, this disease process that led to symptoms eventually. These are generally going to be more systemic unless you're dealing with trauma, impact trauma of some sort, okay? So anytime you're looking at a systemic issue, you're going to be looking at the substances, particularly Shen, Qi, and blood in particular. All right, so branch treatments are for the symptoms, right? These include any kind of channel level imbalance, local tissue damage, external pathogenic factors, Qi and blood stagnation of the local area. So I'm reading off of top of my page 3 of this document. So when I'm considering my treatments, I'm thinking about root branch. And again, what seems to be the most severe imbalance? So I can't really teach you like a formulaic way of when to do root, when to do branch. There are times, like I said, so that's why I've given you this guideline of like 8, 9, 10 out of 10 pain. I will generally treat whatever seems to be leading to the most pain, or maybe later on when you're doing internal, when you're talking about internal conditions like, vertigo, dizziness, asthma, things like that. Anytime you're dealing with wind, generally that's going to be something that you have to deal with, whether it's internal or external wind. That's generally something that you're going to want to deal with ASAP. Like first set of needles are going to be like working on wind. It is the spearhead of disease, whether you're dealing with an internal condition like vertigo, dizziness, something like that, or you're dealing with, with like a severe underlying deficiency, maybe of blood, liver blood, or kidney, Qi and Yin, right? These are things that allow wind to arise internally, externally, or very weak Wei Qi, right? Which allows wind to invade. And that Wei Qi deficiency could be based on some other internal deficiencies, right? With earth or water particularly, right? Or you're dealing with, like external wind, generally you're going to want to work with those first, okay? But again, whatever seems to be like upsetting the patient's ability to be present, whatever is really interfering with the patient's ability to be present, whatever is getting in the way of their ability to be present, like that's what I focus on first. And sometimes dealing with the root right away can do that. And sometimes dealing with the branch right away can do that. And you're just going to have to experiment with that on your own. But I've given you some guidelines about how to think about it, right? One of which is how much pain are they in, or what's the intensity of their symptoms. If it's 8, 9, or 10, whatever that is, that's what I start treating first, okay? And then if wind is involved, then I definitely got to address that right away as well, okay? All right, any questions about that? Okay, all right. Systemic signs generally are going to be more connected to the root, and this will be more perceptible on the pulse, on the tongue, and the symptoms correspondences, okay? So Whitfield Reeves' book is great. He's given you this wonderful outline of kind of like this step-by-step process of treatment. And on the outside, it looks like, okay, I treat this first, then I treat this second, and I treat this third. But really what he's given you is similar to what I'm giving you, which is treatment options. Again, like he, in his book, doesn't really, he gives a little bit about assessment, but not much, right? He gives you a little bit about like how to diagnose what's going on. But what I'm trying to emphasize is that, you know, when he lists the sinew meridians first, and then maybe like the opposite extremity, and then maybe the opposite side, you know, like upper, lower, or left, right, and then the shoe point, you know, combinations, and then so on and so on. What I'm emphasizing for you guys is to test these out, right? To do the proper assessment tests to see if it's warranted and what degree of severity or intensity, you know, of pain or discomfort or symptoms does these provoke, right? On a 1 out of 10 scale. And that's how you would organize your treatments, right? So if I'm testing the sinew meridians first and the bladder's like 8 out of 10, gallbladder's 6 out of 10, I do the primary channel treatment, primary meridian assessments, and they're all like 4 and 5 out of 10. You know, what do you think I'm going to do first? I'm going to do the sinew meridians, right? If the sinew meridians, if it's switched and the primary meridian tests are the worst, I'm going to do those first, right? Tonification points and or sedation points, right? If I do one of the orthopedic, like sinew meridians, it's like, 5 out of 10, 4 out of 10. Primary meridians, 3 or 4 out of 10. I do these certain orthopedic evaluations. Whoa, wow, okay, right? Then I have to treat like what that implies. So maybe I'm looking at, you know, motor points. Maybe I'm looking at master dung or channel balancing points that deal with that. Maybe I'm dealing with local Usher points, okay? All right. So, you know, Whitfield Reeves gives you a great list of, and a great way to proceed from most distal to most local, and it's fantastic. But you're not going to be able to just treat these things in order. You know what I mean? It's not like a recipe. Okay. Does that make sense? That you're not going to like just do all of these treatments on everybody. Like you have to have a way of discerning which ones to treat and which ones to leave out or wait till later. And that's what I'm hoping I'm giving you. At least that's my attempt, my intention, to give you these things based on the assessment tools that I've given you. All right? Because frankly, there's not a lot of books that have a very complete or comprehensive list of assessments. You know, even in Leggy, which I love, but you know, the assessments are you know, it gives you a few, but not a lot. All right. If you want a more thorough understanding of the inner nature of the Master Dung points, you know, again, I highly recommend this book. You don't have to get the 6th edition, right? It's by McCann and Hans George Ross. He looks like the most interesting man in the world's brother. He is a very handsome. I love his pose. It's great. Isn't that great? That's a guy with like a good sense of wood. I'm a very handsome man. Right, so but that can give you an understanding of like the meridians that it balances, you know, why these points work. They're not just like some weird empirical point, like, yeah, we just noticed that works. I mean, they give you a good understanding of why, all right? But I've given you a lot to start off with, okay? All right, so, all right, let me just check my notes here for a second. Yeah, so if I suggest a sinew meridian treatment in this list of treatments, I'm figuring that your test of a particular sinew meridian was positive based on the specific impaired movement that provokes more pain than any other test. So, and this is where the advanced part comes in, is if this sinew meridian tests positive, it may, with a capital M, it may imply other factors are involved that resonate with that particular sinew meridian, with sinew meridians in general, and that particular sinew meridian specifically. So here's what I mean by that. And again, these are things that you're going to then follow up on and assess based on signs and symptoms. So if somebody comes in and the worst, like the one that made their hip pain the worst is like the gallbladder. Gallbladder may imply, the gallbladder sinew involvement may imply that the wei qi is damaged in a way that affects the gallbladder, and that may involve damp heat. So I want to look to see if the external pathogenic factors of damp heat and maybe a lot of internal dampness generating heat is present. And one of the things that affects the gallbladder the most internally is damp heat in the gallbladder. In fact, there's a pattern of disharmony called damp heat in the gallbladder and liver. So then I'm going to look at the tongue, I'm going to feel the pulse, I'm going to go back and look at my signs and symptoms to see if damp heat is present in any kind of significant way, right? So the fact that the gallbladder tests positive implies it's possible for damp heat, that's Xiaoyang, right? Gallbladder Xiaoyang, that damp heat may be present as an external or internal pathogenic factor, right? With Taiyang, small intestine bladder, that implies the possible involvement of wind cold. That's Taiyang, possibly wind cold, right? And then with Yang Ming, that implies possibly wind heat, right? And with Xiaoyang, gallbladder triple heater, that's damp heat, okay? Now, I'm mentioning these in terms of the yang sinews because the yang sinews are the most susceptible to external pathogenic factor invasion. Generally what happens is this yang sinews are affected first and then the yin sinews are affected second. The exception to that might be some kind of impact trauma, right? So that's why I'm going through this. So why would I say you should check out to see if damp heat is involved in some way? Because you may want to fold these damp heat resolving points, like damp resolving heat clearing points, depending on where the damp heat is showing, which often shows up in the joints, because that's, you can add points that then more thoroughly heal your patient. This also might imply certain herbal formula strategies. This also might then guide you in your choice of liniments and plasters. Does this make sense? Now you may be thinking, oh my God, I don't know how to do that. I would disagree with you. I think we've outlined what signs and symptoms of wind, cold, heat, and damp are. These show up in the notes in the first couple classes. They're in the assessment and diagnosis essay. They're in Machocha. They're online, you know, like no worries, right? This is the one aspect where it's like, this is not rocket science, right? And so when you can include these types of points in your treatments, you can kind of checkerboard them and look at it as more of like a root type treatment. And then the root of that root is almost always dietary or environmental exposure. Then you can really, really help your patients. It's going to influence how they eat. It's going to influence, like right now, like we keep our house pretty cool, right? Because, you know, I don't like to spend $1 gazillion to make my house hot in the winter, which seems to violate nature for me anyway. So I'm I'm in the basement, so it's a little cooler here. And I'm also next to a very large sliding glass door window. So I've got, you know, a flannel and a scarf, right? So, I mean, I simply said to my one patient, like, okay, for the next 2 winters, like anytime you leave the house, you're wearing a scarf. And she was like, ah. I'm like, well, you know, you're a pretty snappy dresser. Like this gives you an opportunity to kind of like, you know, like whoop it up your accessories. You know what I mean? Just like, you know, accentuate your accessories collection. She's like, yeah, I never thought about that. Right? Okay, so now everybody knows what to get you for Christmas. Oh yeah, right. And And you know what is funny? It's like, so like she started wearing a scarf and she needed less treatment and, you know, fewer times. So that was good because, you know, she didn't really like, she was very like type A, didn't want to take off time from work to come for treatment. And it's like, she sent me an email like 2 years later, like, this revolutionized my life. And I just told her to wear a scarf, right? Everybody's grandmother, like, so this is what I'm saying. Like, so like you're susceptible to this type of thing. So we changed the way she ate. We changed the way she dressed and she was so much better. It like changed her whole life, right? It saved her a ton of money in treatments too, right? So this is what I mean, all right? So there's other obvious correspondences that go with sinew meridians in general, particular sinew meridians like specifically, right? The elemental correspondences, the correspondences of the officials. So these are the things that you're going to look for, right? When primary meridians are out of balance, sinew meridians are out of balance, right? Sinews are about Wei Qi, primary meridians are about like the Yin Qi, sinew meridians are about our reactivity, right? Primary meridians are about how we kind of be and relate to our internal and external world, right? So these are things that like, you know, you're not just, you know, healing the sinew, like you can reach them at a very, very deep level. And you can also, you know, use that as a doorway to investigate other phenomena, other signs and symptoms that may relate to these external pathogenic factors, internal pathogenic factors, and so on. All right, is that clear? Does that make sense? This may seem daunting, but honestly, after you start practicing for a little while and put this in place, and I've literally like had my notes out, like reading my notes, like while treating my patients. They don't care. They just want to feel better, right? Maybe some of your metal CF patients might care, but whatever. They're going to appreciate that they feel better. You know, just say, well, you know what? This really reminds me of something. I just want to check my notes. People are fine with it, you know? Just have them lay down, relax, put some nice music on. It's cool. Okay. So on page 4, lots of bullet points. I'm just going to go over this very briefly and then we'll take a break. So later on in these notes for the hip and low back, I've went through this morning and divided them up into yellow, blue, and green sections. I'm sorry, the green showed up a lot lighter and more translucent and easier to read on my computer screen than it showed up on the paper. So I apologize if that's difficult to read. But you know, if you want, you can like just change it to another color or take the color out, whatever. Brooke?
So the color didn't come through at all.
Oh, really?
If I'm on the same document you are, I have 0 color.
Okay. Huh.
Me too. Yeah.
Okay. I'll
I see where you have a
the code.
key to the colors, but there's no
Right.
color.
Okay, at the break, I will take down that one and try putting up the one again I did this morning, and that will have the colors. Okay?
Okay, thank you.
All right. Sorry about that. So, okay. So you can combine points from each primary, secondary, tertiary strategies. These are for me. Like, these are how I prioritize them. You know, you like for Whitfield Reeves, he gets like a whole lot of value out of these shoe point combinations. I get moderate value from the shoe point combinations, right? You know, Lonnie Jarrett wrote in his Red Book, this great book with lots of really cool treatment suggestions. Almost none of them work for me and my patients. Does that mean his treatments are crap? Of course not. That means that's what works for him based on how he relates to the material and his patients. You're going to have a different relationship to the material and your patients than me. So some of the things that I love maybe aren't going to work great for you. Some of the things that, you know, I'm like, you're like, man, this is the bomb. You got to experiment. This is where connecting to your internal guidance is very important. Sometimes I don't get something specific. Sometimes I get like guidance to look in a certain book. And then I look through that book and I'm like, oh, I found this thing. I'm like, oh, now okay, got it. Right. Oh yeah, right. I never thought about using kidney 6 this way. Okay. So the general guidelines though are, I like to clear introductory blocks first. IDs, EDs, AE, husband, wife, CVGV, which is rare, Akabanis, except like I said, when the patient's in severe distress, because as I say, it's hard to cultivate an observer when pain is all you observe. I thought that was pretty catchy. All right. So if the patient's pain is very severe, I try and do what I can to alleviate that, which might be sinew meridians, it might be master dung points, it might be channel balancing, right? It might be local ashi points, right? I like to start with distal points first and local points later. So when I talk about my treatments, in my mind, you know, because I take insurance, you know, you can bill like 3 to 4 units. You know, a unit is like every 15 minutes, which is really like 8.5 minutes out of every 15-minute block. So if you're starting a patient, you know, if you're doing a patient every hour, like you could bill for 4 units. So that's the way I've kind of like divided it up into my head. And I realize that's conceptual based on outside concept, but it works for me because also I think about within one treatment, hour-long treatment, you know, I might put a set of needles in here, you know, okay, my first set of needles or treatments might be like distal points, sinew meridians, cupping gua sha, maybe some needle usher or motor points with e-stim, right? And then, you know, my next set might be like more adjacent points or shoe point combinations, right? And then the last one might be like local points, local usher, local empirical points, maybe local named and numbered points, like if they have low back pain, maybe like that third set is when I maybe go to like, you know, do 4 and bladder 23 and, you know, bladder 47 or 52 and we're in the TCM, you know what I'm saying? So like I start at distal and work towards local. Is that a hard and fast rule? No. Especially when you're doing like cupping and gua sha, obviously you're going to cup and gua sha the local area. All right. But that's in general, I prefer more distal. I get more results from using distal points first and local points last, especially when I'm needling. The exception obviously is manual therapies, cupping, gua sha, massage, laying on of hands. And I'm not joking when I say that. All right. So I generally go for the sinew meridians first. They're the most distal. They allow for a freer circulation of wei qi. They dispel EPFs, external pathogenic factors. They release internal tension that is put on the primary meridians and the tissues by these external pathogenic factors. It's like creates a lot of pressure in the system. It also secondarily, indirectly helps the free flow of qi through the primary channels. It also is said to open the portals, which means it like wakes people up. It stimulates the sensory orifices, right? It stimulates the sense organs. And that also helps them to be more present, right? To more than just their pain or discomfort, right? If I'm treating a sinew meridian, I often bleed 1 or 2 points, including the Jingwells, right? For low back and hip, that's often bladder 40 or some kind of like very obvious vein on the back of the popliteal crease, back of the knee crease. Also bleeding lung 5 is phenomenal. So what I do is I put I know you're not supposed to put cup on like over bladder 40, but you can do gentle cupping for like a few minutes on the back of, you know, bladder 40 or lung 5. That kind of like draws some blood to the area. And then then I take the cup off, I put it back in the pump, and then I lancet it, you know, once or maybe twice. And then I put the cup back on and I draw like some blood back out. Okay. That is phenomenal. That moves any kind of blood stagnation, right? Again, we talked about the sort of like the sort of molecular cohesion of liquids, of especially viscous liquids, to help move that blood stasis. And that relieves a tremendous amount of pressure from the area it relates to, in this case, which is the low back and the hip. All right. If a sinew meridian treatment is not necessary, then I generally, more often than not, work on the primary meridians using generally the tonification or sedation points or the shoestream combination. Or I might go directly to cupping and gua sha. If a patient's problem is predominantly with flexion, extension, or rotation, I'll treat the Dumai or the Renmai or the DIMI respectively. So this comes back to your primary channel assessments. Remember back, I think it was like in class 3, and we also, I think, discussed it a little bit in 4, where like if a patient, like I went through all those exercises and I've put them, and they're also in that Dr. Yoshido's book, right? Sports acupuncture. Like, okay, they bend over this way, it implies, right? Like they bend over at the waist, or if there's some kind of flexion or hip knee flexion, that's bladder, kidney, and DUMI, right? Extension, right? Back torso extension, hip or knee extension, that generally is stomach, spleen, and CV, right? Rotation is gallbladder, liver, and DIMI. You guys remember that, right? Okay, all right. And then I may or may not add, a couple of additional points to support them, which includes points along the trajectory of those primary or extraordinary vessels. And then, that may also deal with a substance. It may also deal with an external pathogenic factor, or they may be points along those trajectories that deal with the spirit of the patient, right? So I generally like to include some cupping, gua sha, or e-stim when possible, right? If signs and symptoms of EPFs are predominant, I'll generally gua sha or cup earlier in the treatment, generally in that first set, right? Within those first set of needles, the first third or fourth of the treatment, right, of that hour. If muscle tension is predominant, I like to do e-stim, okay? And we'll talk a little bit about the details of e-stim later in the course. And at some point, while other needles are in, I generally will include 1 or 2 master dung points or channel balancing points. So in this case, for the low back, I'm going to be doing points like around the elbow crease, around the knee crease. If it's down to like into the SI joint, or like right at the sacrum, or into like the greater trochanter of the hip, that's going to mirror around the waist or ankle crease, okay? And if it's lower than the sacrum, like the SI joint, like getting like towards the bottom of the SI joint, or maybe into the ischial tuberosity, greater trochanter, then that level on the arm, on the upper extremity is going to be like distal to the wrist crease. So that we're looking at like points along the hand, maybe along here, right? And for the feet, it's going to be around the ankle crease, to about like the yin spring points, shoestring points level, okay? And then I'll leave those in for at least 30 minutes or as long as the patient can remain in one position comfortably. And then spirit points, you can do these in a couple different ways, whatever resonates for you. Like, so some I do because like that's like in their presence, like the spirit level imbalance seems to be the most predominant. Then I'll do those points first because the message that those spirit points send set the tone for the rest of the treatments. And so to varying degrees, I'm going to do points that resonate with that treatment message, right? So maybe I do, kidney 23, which is about them like sort of reclaiming their unique power, their unique nature in the world. They're putting their spirit seal on everything. They're signing the painting of their life, right? They're imposing their imprint on everything that they do, and they're claiming it as their own, right? They're stepping into the world in a powerful way. So I may say, okay, now it's time for you to reclaim your power in the world and the power of your unique individual nature, and to bring that forth in a powerful way, whether that's a quiet way or a loud way, to bring that forward and like really honor and own your essential nature, your qualities, your virtues, your strengths, as mundane or weird as they are, okay? And then, so a lot of the points might be around, supporting that, okay, that resonate. So sometimes though, maybe there's so much physical stuff going on, they can't really be fully present. And so maybe, you've tried a spirit point with them and it didn't really kind of get through, that message didn't really get through to them. Like it didn't really change the pulses. It didn't really change their affect. It didn't really change their quality of presence. Maybe I do spirit points last. I do all the physical stuff, relatively physical stuff first. And then that's the treatment message I leave them with when they go home, right? Because oftentimes the thing we hear last is the thing we remember most, right? If a patient's experiencing a lot of radiculopathy, radiating pain, right? I often include the Huatou Jiaji points at the appropriate level. Legge, in his book, Close to the Bone, at the very end of the blue section, is it the very end or the very beginning? Let's see. I thought it was at the end. Yeah, at the very end of the blue section of his book, he includes the front and the back of the dermatomal patterns, right, that are emanating from that nerve root, right? So if you look closely, it's very hard, it's a little bit hard to read, but you know, like if you've got radiating pain, like down, say, the middle of the back of the leg, you'll see it says S2. That means it's coming from the nerve root of the second sacral foramen. Capiche? Right? So I'll want to do the Huatous, you know, at that level, and then one above, and then one below. And you can e-stim those. Okay? And then I'm going to combine those with motor points and or, you know, and probably also G-clef points or shoestring points or trigger points, you know, palpate which one seems to garner the most reaction. And then, you know, e-stim can be applied via this device. It looks like a giant fat pen called a Pointer Plus. They're available on Lhasa. And that just, and you just has this little metal tip. And so here's the needle, and you just zap the needle a couple of times to just very gently give some e-stim to that motor point. Or if you need, you know, if it's really severe in terms of stagnation or deficiency, then you can kind of clip the alligator clips and use some kind of e-stim device. Like I use a Edo, I can't remember, like 350 or something like that. It's whatever it's the 3-channel one that they have on Lhasa. And keep an eye out. Occasionally they have some really good sales. I got mine at like 25% off, so that was cool. And then you can also, yes.
I have a question, but it's not directly related to the material. Would you like for me to wait?
Yeah.
And ask it later? Okay.
Yeah. Bring it up after the break. So you can combine multiple strategies. Again, think about what is it that you're trying to do and what level are you treating on, body, mind, or spirit, and which one seems to be getting the most in the way of them being present and functional. And so I generally try to limit to about 6 to 8 points in the beginning. You may find yourself doing about 10 to 12. That's not so bad. And then of course, always trust your inner guidance. But as Reagan said, trust but verify, right? So I do like to verify my inner guidance by, you know, applying the knowledge that I have of Chinese medicine to make sure that all of my ideas are grounded in patient phenomena. Okay, that's very important. So if you know, there's a continuum of treatment where like some of you are going to be more intuitive and some of you are going to be like more, I don't know, for the lack of a better term, like protocol oriented. Both are fine. Both are fine. But if you're not really with your patient, if you're really with more about yourself, either your own inner impulses and impressions, or with the your inner knowledge and like what's written in books, if you rely too heavily on these treatments, your treatments are going to get sloppy, and they're going to be like uncohesive. They're going to lack cohesion. They're going to be kind of like scattered and all over the place. They're going to be relatively sloppy, and these can tend to make you a little bit dry and soulless, right? So, you know, with different patients and, you know, different times in your you know, in your career, you're gonna oscillate or vacillate between, one or the other. Okay. All right. So always make sure that your inner guidance kind of resonates with and is grounded in patient-oriented phenomena. Okay. All right. Any questions? All right. So let's take a break. I'm going to re-upload the notes that hopefully have the color-coordinated details along with the treatments. And then we're going to start going over conditions of the hip. Anytime we're dealing with the hip, again, like the back, we want to make sure that you've assessed the posture in terms of anterior pelvic tilt, posterior pelvic tilt, elevated ilium, right, or rotation. So I've given you some guidelines about how to do that and the muscles that were involved. If you look on page 1 of your class 9 notes, down towards the bottom, you'll see the muscles that are involved that are called locked short and locked long. So locked short, locked long were terms that I've kind of got from Matt Callison. I don't know if they're industry standard, but basically if something is shortened and overactive, right? Spasming, contracting too much, that's shortened. That's the locked short. The locked long means they're lengthened and inhibited, means they're weakened, okay? So this shows you which muscles are involved with torquing the hip, the pelvis in different directions, okay? And I've even included some treatments for that. There is a PowerPoint on orthopedic evaluations. I didn't have time to go through the whole thing last class, so I would ask that you look at that on your own time. I've given you some of the major, what I've done is just outline some of the more prominent tests, the common tests that I use, and there's some pictures, as well as some, on the notes, I've given you some links to some videos where you can look at them online as well, okay? All right, so, you have to rule out anterior pelvic tilt, posterior pelvic tilt, elevated ilium, or rotations, okay? And so in that next few pages, 2, 3, and 4 are basically a repetition of what we just went over from the treatment guidelines. So I'm looking on my page 5. It should start with buttock pain. Okay.
I'm sorry. You're on a new
notes?
document?
Class
You're on
notes?
Not guidelines for treatment.
Correct. Class notes.
Okay.
Yep. I've
you.
included
I'll
the
find those.
guidelines for treatments in the class notes, but we just went through those, so now I'm on page 5. Should look like this. Buttock pain.
I'll find it. It wasn't in my guidelines for treatment, but I'll find it.
Right. What I'm saying is I've also included, like, the guidelines for treatment. I've separated that out, but I've also included them in the class notes because afterwards I was like, oh, I should make this like a separate document.
Okay.
Okay. So class notes, page 5, it should start with buttock pain. Generally, this is more muscular. It's going to involve like the glute maximus muscle. It can involve the low back muscles as well. It's usually some kind of strain. It could involve the hamstrings as well. It may be, generally postural assessment is very important here for the low back and the hip, and in terms of any kind of gluteal pain. You definitely want to test the do the muscle test for the glute max, the glute medius, the glute mins, and the piriformis muscle, right? And then I would also palpate around to look for any kind of trigger points, right? Legge has some good indications about where the trigger points are. You can also look in Terrell and Simon's, the myofascial pain book on the trigger points. Mainly the tests I do are to rule out any kind of nerve root involvement, which is the straight leg raise test. I generally, sometimes we'll do the slump test, right? If the straight leg raise is positive. If the straight leg raise is positive, again, I mentioned on a small percentage of people, the piriformis muscle, the sciatic nerve goes through the middle of the piriformis muscle. So if the piriformis muscle is shortened and overactive and is like clamping down, you know, it's like in a state of contraction, it'll clamp down on that piriformis muscle. And you'll get this sort of like paresthesia and maybe some slight radiculopathy, but not past the buttock. It won't really go into the leg. But it'll be like sort of radiating through the area of like maybe around the sacrum and the glutes. Okay. Occasionally it will radiate down the leg, but it won't be pain. It'll be more like tingling. So you won't get pain radiating down the leg. You'll get more like the paresthesia, that sort of numbness, that tingling sensation that goes down the leg. And that almost never goes past the knee. I've never seen it go past the knee. Okay. So, you know, you may get this radiating sensation, but it shouldn't be that painful. The achiness is mostly confined to like the hip and buttock area. And this is almost muscular by nature, usually involving the glute max, glute med, glute min, and possibly the piriformis. I also, may not be on your notes, but I also check the psoas, which is the anterior muscle sort of to the posterior piriformis. So that's that yin-yang balance. So if the psoas is out of balance, I'll treat like either the motor point with or without e-stim, or the trigger points involved with the psoas. Okay. So there's a trigger point halfway between the PSIS and the greater trochanter. This is close to the TCM location of bladder 54. It's in the region of the sacrum. It's about 3 cm lateral to the middle of the sacral crest. That's at about the level of the 4th sacral foramen. So that's a nice point. I would use at least a 2-inch needle, maybe 3-inch. I would get some 3-inch needles. Right? You can take a cotton ball or a prep pad and support the base. So you tap it in and really, like, you know, I hold the needle lengthwise like this. I don't hold them like this. I hold them like this. And I push that needle down in gently and slowly. Depth does not equal pain. Okay. This can be a deep point even on, you know, relatively thin people, but for those of your patients who are relatively well upholstered, you know, you're going to need at least a 2-inch needle, probably a 3-inch needle. This feels so good when this point is released, when the tension is released. There's also some trigger points located in the belly of the glute max and glute med. You can palpate around. I've given you some indications about where they are. Again, I would use a 2 or 3-inch needle. Then I palpate gallbladder 30 and gallbladder 34. If it feels reactive to either the patient or myself, I include both on the same side. If there's like a lot of paresthesia, if that radiating numbness, tingling is quite intense, I may include like the Huato Jiaji points at like L5S1, right? Sometimes, because that inflammation of the piriformis muscle, this is not in your notes, that inflammation of the piriformis muscle can kind of like radiate back and track back towards the spinal nerves and the spinal cord, or excuse me, the spinal vertebrae. So, you know, it may not just radiate distally, it may radiate proximally as well. So sometimes the Huato Jiaji points can help relax and move any of the inflammation, clear some of the inflammation that's building up around where the piriformis attaches, and where the, you know, nerves that innervate the piriformis, you know, attach to the spine. Right? I've mentioned you can needle into the SI joint. When I started, you know, I didn't have any guidance about how to needle the SI joint. So I was needling medially. So if here's the SI joint. Right. So if here's the the iliac crest, right? This is the sacrum, then you've got like the sacral foramen. Right? And then along here is the SI joint right in here. Right? I don't know why, but it just seemed to me that I should be needling medially. And then Whitfield Reed said that actually you want to needle it more laterally. So like at about a 45-degree angle, like this way. Does that make sense? Can you all see that? And
Yes.
I found that I can get it more. I mean, you're not really
Yes,
needling
thank you.
into. I'm sorry. Did you get it?
Yes, yes, I understand. I see it.
Okay. And what I found is like I mean, technically, you're really not needling into that joint. It's it's a forced closure joint. It's pretty hard to get in there. But what you're getting at is you're pecking at the top of that joint crease, right? And you're perfusing that area with chi and blood based on, you know, the ionic principles of using a metal needle, right? Attracting, you know, more to that area. So I've gotten better results doing 45 degrees, like sort of posterolateral, like kind of down and out, about 45 degrees with a good 2 or 3 inch needle. Right? I wish they made a 2.5 inch needle. That would be like just perfect. So you can put Moxa on top of the needle and Moxa needle that. Man, that is awesome, especially in the wintertime. Older folks, you know, like arthritic, it's like, in the wintertime, you know, it's like, you know, they're like grabbing their hip. And you can really do this for like SI joint issues. You can do this with buttock pain. You can do this with even like hip stuff. Bringing a lot of like warmth and chi and blood to that area can really help like relax that joint, because it is a joint, and that can have sort of radiating, cascading effects, right? So I mentioned it here first, but it's something that you can do with really any SI joint problem, or even people with just, you know, like like you have your patient coming in with other stuff. They come in with like this occasional, like sort of really, really low back, sort of at the level of the sacrum. You can Moxa needle the Liao points, bladder 31s through 34, although I wouldn't worry about 34. It's hard to get to. I would just do 31, 32, maybe 33 even. You don't even often have to do all 3 of those, just 31, 32. Deep needle, Moxa on the needle. You can also do cupping before that. I don't really cup the buttock. It doesn't really seem to help that much. But Ashi points also, like in terms of channel balancing and tissue balancing, the deltoid is what mirrors the buttock. So front of the hip, lateral side of the hip, posterior part of the hip, right? So the glute max is going to be like the posterior deltoid, maybe even like up into like the teres minor. So you can do some deep needling of Asher points on the posterior aspect of the opposite deltoid. Great treatments. There's also a couple of Master Dung points that relate to that area. One of which is called 2209, which is like about, I don't know, small intestine 4. It's about like 2/3 of the way between 3 and 4. It's kind of like just over the distal head. Yeah. It's just distal to the proximal head of the 5th metacarpal. It's like small intestine 3 and 2/3. Those are great points for like buttock pain. Generally, it's muscular in nature. You know, you can have the patient kind of like foam roll this out or get some kind of massage. I don't massage my patient's glutes. That's just me. All right. All right. So moving into the hip. Again, on a spirit level, the hip has a lot to do with how we experience power and stability. And with the power, it's not just about enforcing our will on others. It's not just imposing our plan on the rest of the world. It's not about like the power to manifest one's vision. This is more about the power one needs to generate, like to create a sense of stability and some moderate flexibility in your life, right? So maybe the difference between owning a home and renting a home, right? If that's an issue for you, right? Like, you know, okay, technically, yeah, maybe the bank could take it away from you, but like owning your home is a little bit different, or owning your car rather than like, you know, leasing a car, right? So it's like, is their situation in life kind of tenuous, right? Is there stability? Do they seem grounded in a way that allows them some different options in life? You know, you want to be flexible, but you also want to be sturdy. And this is like, you know, sort of the seat of like just below the kidneys, right? So this is like, you know, I mean, the hip is like this bowl, right? That the sacrum, right, which is related to the kidneys and Ming and Dantian and Ming Men, right, lower Dantian. So this is like the container for the power, right? And it's a very bony structure. So there's a lot to do with Jing, a lot to do with the hidden aspects of our life that do or do not provide stability for us. So this will be like your deep belief systems, right? Your truisms, okay? And can we be flexible with them as well, right? Can we learn and grow that, like, oh, you know, maybe there's a more of a gray area here than it's all black and white. I also look at what's their pace of life, because hips allow us to move forward. They are tilted anteriorly because we are meant to move forward. We're not meant to stand still, figuratively and literally. And there's a saying, an old saying, when you move your thighs, it's exercise. Have you heard that? I like that. So, you know, are people like exercising their hips? Because when that's stiff, you know, it like really impairs our ability to move around and be flexible. And so I also look at what's challenging their pace of life, aging, you know, demands on their life. So I have them reevaluate the pace of their life on a daily basis. You know, are they running around too fast? Are they going really slow? Are they feeling inert? Do they have a lot of big decisions to make? Remember, you know, what activates the hips is mostly the gallbladder, assisted by the bladder, to some degree the kidney, and the stomach spleen, right? And maybe a little bit with the liver, but not so much. So, you know, do they need a kickstart to get moving? You know, are they kind of inert? You know, have things like gotten cold and stiff? Or, you know, do they need, are they too hot? Are they running too hot? Do they need to slow down a little bit? All right. So I've gone over the basic anatomy of the hips. That's at the bottom of page 5. I've listed the ligaments and the joints. I've listed the muscles important for the hip action, hip function. I've given you a link on Wikipedia. I've looked at the different movements of the hip. This is the middle of my page 6. Hopefully it's yours. Movements of the hip joint and the principal muscles involved for these movements. So why did I give you that? Because now you can look at different movements in terms of the primary channels, right? Flexion is kidney, bladder, right? Extension, spleen, stomach, right? Rotation, you know, gallbladder, liver, and then specifically abduction and adduction, right? And if you know, that way it gives you a sense of what the primary channels that might be involved. And then also, based on this, it's like you can look at different muscle tests to perform and possible motor points to treat, right? So I've done kind of like my goal is to like do a lot of the legwork for you and to help organize the information so you don't have to go hunt for it. Like, well, okay, they have trouble with flexion. Well, I wonder what muscles are involved with that. And then you have to go look that up. Okay, well, and then do I trust the source? And then, okay, you know, then maybe I'll have an understanding of what muscle tests to do and motor points to treat. And I'm still in the process of uploading muscle tests to my YouTube channel. I'm a little behind in that, but I'll get caught up. And then the primary and sinew meridians that are really important to hip function, I've listed them there. And then examinations, of course, check Akabanis. This is the bottom of page 6. You want to visually inspect the area. You know, sometimes doctors, PT, you know, they don't look at the area. Is there bruising? Is there inflammation? Is there swelling? Right? You want to look at that. You want to feel for the area, the tonicity, the temperature, any swellings, any tender points. Right? You want to check their range of motion. Right? Flexion, extension, abduction, adduction. So abduction is away, adduction is back towards the center. Right? So adduction, I think of it as like I'm adding to the mass of my center. Right? Abduction, right? Going away. And then rotation. Okay. Any questions about that before I move on? Okay. So
Time
there's a
to,
couple, yes.
sorry, I wanted to let you know that at least on my copy, the color has shown up now.
All right. Sweet.
So I don't know how it happened, but I can see the yellow, the blue, and the green.
It's simply the power of prayer.
Yes.
There's
That's
no
exactly what it is.
other logical explanation.
That's funny.
All right. So, you know, one of the things I do is low back, hip stuff. Actually, I do it on all exams now. Is I have the patient stand up. I'm sitting in front of them. We're standing in front of them. I have them close their eyes, bring their feet together with their eyes closed. Then with their eyes closed, I have them spread their feet apart to what feels like shoulder width distance apart. And then I have them open their eyes and I look and see like how their feet are pointed, right? Are they more on one, are they putting more weight on one foot than another? Are their feet moving in different directions, right? So that gives me a sense of, okay, you know, if they're pronating on one foot or, you know, if it's out in this way, right? That tells me that there's muscles in the legs that are attaching to the hip or the knee that are out of balance, right? So I really want to double check the posture. There's a couple of other tests here. The Faber test, which is flexion, abduction, extension, and rotation. Is that right? Flexion, abduction, extension, rotation. Yes. So this gives you a sense of like restricted, if there's restricted range of motion. With groin pain, that definitely indicates a hip problem. If it's restricted range of motion with SI joint pain, then it's generally like a low back SI joint issue. Okay, so then I would do the SI joint rocking test, right? Which is this very complicated test where you have the patient lie on their back and then you bend their hip and knee up to bring their knee towards the opposite shoulder and get to about end range and then just rock back and forth. Very complicated test, takes years to perfect. All right. So if that elicits any kind of discomfort or pain, then you know it's definitely like in the SI joint. Okay. The Faber test is kind of like they would bring like one foot up to their opposite knee, kind of like making a figure 4, and then you bend that knee down towards the table. Does that make sense? It's almost like you're crossing, it's almost like they're crossing their legs at the knee, right? Bringing like one ankle, bringing like the lateral malleolus over like the top of the knee at like Hoding or spleen 10. And then, right, so the leg is like this, and then you're bringing that leg down, you're pushing the knee down to kind of expand that figure 4. All right, that's the Faber test. All right. I believe that's named after the founder of Faber College that was made famous in Animal House. All right, so postural assessment. Again, looking at how the relationship between the ASIS and the PSIS, right? I've given you, yet again, assessments by movements for the sinew channels, right? Just as a reminder, so you always have it handy. Obviously, we're going to be dealing with the lower body here, so you can forget about the first 6. And also, consider the type of pain. So in the assessment and diagnosis essay, that long essay that I have on Canvas. One section of it is entitled Type of Pain, and I have illustrated for you many different types of pain and what they imply, which then allows you to then go re-examine signs and symptoms to see and to discern, is this achy pain because of this or because of that? And if it's because of this, then these signs and symptoms are going to show up. And if it's because of that, these signs and symptoms are going to show up, right? So it might be cold or it might be blood deficiency, right? Now, both might be there. It's not just one or the other, right? So you're going to investigate the signs and symptoms of the patient to see if indeed there's cold and if indeed there's blood deficiency, right? Does that make sense? You're kind of like narrowing it down. All right. So bursitis of the hip, also called trochanteric bursitis after the greater trochanter. All right. This is generally a repetitive stress disorder or some kind of acute impact trauma, either a car accident, somebody's fallen down and hit their hip. And it's led to some kind of inflammation in the area of the greater trochanter. All right. And so the bursa, I've explained, are like these jelly-filled sacs that are like cushions, right? They're like shock absorbers for the joints. And, you can look on, I've included on Canvas a number of images, several images, in fact, of the various bursae that are located in the hip area, right? So you can look for those. Getting a sense of like where they are, I think, is important because that's going to guide you in your palpation. Now, again, these are between objects, right? Because they're meant to be a cushion, right? So, you're not like generally palpating right over the bursa. But what I found is, weirdly enough, like where those bursa generally are, even though they're not, palpable through the skin, palpating over that area, if there is, bursitis, it will react as Usher. It's very interesting. So generally, if there's some kind of bursitis, for me, like the key assessment, in addition to pain upon palpation with my palm, like the heel of my hand or my fingers, is patient cannot sleep on that side at night. That's sort of like the deal breaker symptom for me, in addition to pain with palpation. They just say like, either they can't lie down on their side at all, or they can't lie down on their side for like more than 15 minutes or so, or it wakes them up at night. They're laying on their side, they're a side sleeper, and the pain wakes them up, sometime within like a couple hours of sleeping. That for me is like the deal breaker. Now that doesn't mean it's the only thing going on. You'll test for other stuff, but that for me is like the key sign and key symptom of bursitis. They might feel a little bit of a popping sensation with hip flexion and extension. There might be an ache or a sharp pain very briefly that goes into the gluteal region. It may even go down the IT band towards the knee. And rarely, occasionally, but ever so often, it might go medially into the groin, okay? Like into the medial knee crease, hip crease, excuse me. Also, any kind of exercise they do, or like walking for a period of time, the shorter the period of time is generally going to equate with the degree of severity of the problem or the age of the patient. And you definitely want to check for pronation or supination of the feet. We're going to get to that later on in the course. But that could be torquing, right? If the muscles are out of alignment, if one muscle is pulling in, on the medial side, and the muscles on the lateral side of the leg are weak, or the knee are weak, it's going to be pulling the foot in a certain direction. And that might be torquing the hip joint. Gavish? Right? So, because again, this is like, imagine like a rubber band strung between two places, like the knee and the hip. And if you torque that knee, and over time, it's gonna put pressure on that hip joint as well, right? Because if I'm torquing it this way, then eventually that's going to torque that way too, and it's going to put pressure on that joint. and the bursa are the shock absorbers in that joint. Okay, so the treatments are pretty much listed there. 1 through 5 are in yellow, hopefully. 6 through 11 are in blue, and 12 through 17 are green. That doesn't mean I do all the yellows, then I do all the blues, then I do all the greens, right? Again, I'm saying these are like my primary considerations to rule out first. These are the yellow ones are like the primary considerations to rule out first. Do I always do cupping and gua sha? No. Do I mostly do cupping and gua sha? Yes. I don't always bleed gallbladder 44, but if the sinew meridians are involved, especially the gallbladder, if that tests positive for pain or discomfort, or even extreme stiffness now, I'm including that. If it's extremely stiff and impaired range of motion in that movement for the gallbladder, that rotation, then I'll more often than not bleed that point. If I suspect there's a lot of other signs and symptoms of EPFs, you bet I'm going to bleed that point, right? Because for all the reasons we explained about what Jingwells do, okay? And so I'll do like the whole soup to nuts sinew meridian treatment. I'll bleed the Jingwell, or you can just put it in and tonify it, and then do needles superficially around the area of pain, sort of like you're fencing it off, right? And then not into the pain, but just outside the area of pain. I like sinews for me are yang. There's about the yang chi, so I do an odd number of needles. I'm just a little bit OCD that way, maybe, I don't know. But for me, it just kind of resonates. And then I do the gathering point for the 3-leg yang, of which gallbladder is 1, which is small intestine 18. Almost always, not always, but almost always, unless there's a lot of swelling in the ankle, in which case it could be problematic to needle there. Unless there's a lot of swelling around the lateral malleolus, I will deep needle gallbladder 40 on the same side. That seems so effective. It's extraordinary. And it kind of mirrors, because again, this is like, it mirrors if like you were doing channel balancing, like the ankle crease as well as the wrist crease mirrors the hip joint. And I'm also taking account into like system 7, which is same meridian, same side, but I'm doing like an image balance, right? So system 6 is same spot, opposite side. So I'd look at where it hurts on the patient's hip, and then I'd needle points around that same area on the opposite hip, right? That's system 6 of the balance method. System 7 would be same meridian, same side, distal imaging, right? So the hip is imaged by the wrist crease and the ankle crease. So in this case, it's gallbladder. So I'm doing gallbladder, same side at the ankle crease, which is gallbladder 40, right? And if you think about like that lateral malleolus kind of looks like the greater trochanter. So you don't have to just do gallbladder 40. You can palpate around that trochanter and either bleed or needle around that greater trochanter, that lateral malleolus, to see, you know, if there's any kind of relief in the hip. It's really fascinating. It often works. And then again, more channel balancing, heart 5 to heart 7 opposite side is also images the hip. And then I do include massage, warming liniments, if it's chronic, cooling liniments, if it's acute, and plasters. Again, you know, even though it's in yellow, those are my primary treatment strategies. And generally I apply liniments and plasters last. Generally I apply liniments and plasters last. Does that make sense? Okay. And then there's some other treatments there. So these are like, I'll generally maybe pick 1 or 2 out of these listed in blue, and maybe 1 or 2 out of the green. So I am a little bit partial to the Master Dung points and the channel balancing points, both of which work great for the hip. So Master Dung points, number 10, Wan Shun and there's another one, I think it's Wan Shun Yi. So there's wrist flow 2 and wrist flow 3. The one I was talking about, it's sort of like 2/3 of the way from small intestine 3 to small intestine 4. It's like just distal to the proximal head of the 5th metacarpal, right? It's like right in there on the small intestine channel. And I needle that pretty deeply, but I'll start superficially and I go in real slow, and wherever the patient feels the chi the most, that's where I keep the needle. Now again, you know, hip problems are generally deeper. So when I'm doing channel balancing or master dong, I would needle generally more deeply. But I often now, lately, I've been going more by like where they feel da chi the most. All right, so would I choose some from yellow, blue, and green for the same treatment? You can, yes. So like in those sort of sections, right? But again, think about logistics, right? Map this out in your head. Like, you know, master dong points, channel balancing points, and sinew meridian treatments. Generally, I'm going to leave in for about 30 minutes, right? So sinews I generally do first for reasons I've explained. It kind of like opens the tissue, opens the fascia, makes space for the flow of everything else. So I'll generally do those first when I'm considering all of these, if I'm going to do it. And then I got to think about, well, I'm going to be like having these needles in for 30 minutes. On one hand, I don't want to have so many needles in simultaneously that I'm confusing the treatment message. But on the other hand, I want to give them enough time to really do what they do, because very briefly, what I've found, and maybe some of you have found this too, the patient will go through these waves of experience, like, and this is time going like forwards, right? So like they may I'll put the needles in and I'll leave, or maybe sometimes I'll stay in the room and pray. And then they like in about 15 minutes, they might feel an exacerbation of their symptoms. And then they say, oh, you know, and I hung in there, and after about 5 minutes, it went away. And then I was good for about 15, 20 minutes, and then it started up again. And then I kind of hung in there for a few minutes, and then it subsided. But each peak, like, is lower, right? Does this make sense? Like, you know, first 15 minutes, second 15 minutes, maybe 45 minutes. So I like to take needles out when they're in a trough. Right? So it's like the chi is like working through the system, and then it's like establishing itself, and then it's working through the system and establishing itself. This is all stuff that I've made up in my head. Okay? Like, I didn't learn this from a book. I didn't hear it from a teacher. This is all presumptions on my part. I've experimented with this. This is the best explanation that I have. It's just, I've worked this out for myself based on years of experience. Yeah, so, okay, great. Yeah, John's experienced this. So, and I've experienced it too as a patient, although most of the time, like, I just pass out. So, I'm kind of one of those chi dumb patients. They put it in, I'm like, oh, this is great. Right? And I'm out for like 30 minutes, and then they come back and I'm like, oh, okay. Right? So, but, you know, some of my patients are like more attuned. But this is something that I've experienced. So generally, if somebody's like still in it and things still feel active and they feel their symptoms, like, I don't take the needles out. Like, if I have to make another patient wait, then so be it. I don't want to take those needles out while it's still active. Does this make sense? It's not going to be this way with every patient, but it is this way with enough of them where I've really paid attention. Okay. So yeah. So, you know, think about the logistics, you know, how long I want to leave treatments in. And, you know, if they're a pretty sensitive patient, like, you know that because they either feel it or their pulses respond pretty quickly, I do fewer points. So I'd rather wait for the next treatment to do another set of points rather than throw too much on there and confuse them. And there's no cut and dried formula for what's too much and what's too little. I'm sorry, I can't teach you that, but I can only teach you how to think about it. Okay. So yeah, and it's very common for me to pick, like, you know, one from yellow, a couple from, or one or two from yellow, you know, one maybe from blue and one from green. I generally put somebody asked earlier, John, I believe it was, about auricular points. They don't seem to confuse the treatment. I generally leave them in, so it's nice to actually do first if you want. And they also sell these ASP needles. I don't know if you've ever seen them. It's French. It's like acupuncture, something, 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 something. I don't know. Like, I don't speak French. But I can't remember what it stands for. Have you guys seen these, the ASP needles that are made famous by Battlefield Acupuncture? They look like a little tiny piece of jewelry, and you punch them in there. They're kind of spring-loaded. And so, you know, more often than not, I'll put them in last. And if I'm doing ear needle points, or if I'm massaging, you can massage essential oils on the ear points. Really helpful, right? If you want to know more about essential oils, I can tell you about that later. I've had patients say they hate them. Yeah, it's definitely personal preference. I mean, some people love them, some people hate them. I think they're great. Some people, they're just too irritating, or just the idea of it is like a little scary to like leave with something penetrating their skin, or, you know, again, it's you try it out, right? You learn what's good for the patient, teaches you how to treat them. Yeah, so again, you want to go, when you're choosing these points in these lists, it's what tests positive, and to what degree of intensity does that test result. Yeah, most people only need like 1 point of ASPs. The exceptions are, like, I had this one woman, I actually discovered ASPs very briefly. She had a migraine that had not stopped for, ciao, ciao. That she had a migraine that lasted unabated for 3 weeks. I don't know, like, I've never had a migraine. Doesn't sound too fun. And she was like the most, thank God she was a water CF. I don't think it would, if a fire CF, it would have just killed them. So, right. So, you know, I did some, so I called up John Howard, and I was like, look, John, I got this patient, like, they're just on the urge of like heads exploding. And so he gave me his protocol for like migraines, and damn if it didn't work. I was like, holy crap. Yes, Wood CS would have been very pissed off and probably would have been setting fire to things. So I'm a big lover of ASPs. You know, it's kind of funny, like I go through different phases where like I'll do a certain treatment and then I'm really into it, and then I like experiment with something else and I kind of leave that behind, and then something will come and then remind me, oh right, yeah, ASP needles, yeah, right. So for me, I generally use the ASP and ear points for things that are either like acute and really severe pain, or like it may not be severe, but it's been chronic for a long time. Also, herbs are really good for that. All right, so osteoarthritis of the hip, middle of page 9. So osteoarthritis of the hip is kind of similar to osteoarthritis of the shoulder and just about anything else. They're going to have some kind of a history of injury or trauma. Most people with arthritis are going to be over the age of 40, generally over the age of 60, sometimes in the 50s, especially if they've had a lot of hard outdoor physical work. You know, like my grandfather, he worked for Baldwin Gas Electric Company for 45 years. He had arthritis of everything. And although he was pretty thin dude and muscular, but I've generally found like obesity is a pretty big factor in this. And obesity is probably also the side effect of having a poor diet, which is very high in damp foods, which is, you know, going to exacerbate external pathogenic factors. It's sort of like the flypaper that catches like wind and cold and wind and heat and sticks it into the system. Generally, any kind of exercise, weight-bearing activities are going to be painful. Going up and down the stairs is a common one. Stiffness, getting in and out of bed, making it difficult to bend. It's relieved by rest. It's worse with the weather changes. Oftentimes, if it's really chronic, there's a lot of locking and sticking. They might even feel like the crepitus. I love that word. That's like my third favorite word in the English language, crepitus, because it kind of sounds like what it is. That's that sort of like grinding, creaking, right? And then also, there may be some pain with some passive internal rotation of the thigh. You know, you're moving the leg this way. Often that'll make it worse. It's almost always worse in the morning, and then a little bit better once they get moving around, take a hot shower or bath, they get moving around, it's a little bit better, kind of get some blood and chi moving through the joint. But then after they've been sitting or resting for a while, it kind of gets in, you know, sets in again. And, you know, it's that getting out of the chair. It's like, oh, you know, it takes them a little while to get it up. It may radiate anteriorly to the groin. Generally, it does not radiate posteriorly into the buttock, and it's often worse at night if it's like there's a lot of blood stagnation. All right. There's a number of different ways to treat arthritis. Arthritis must include systemic points, systemic, you know, focused treatments to move blood and to warm cold, if the cold is there, to clear wind, which is there, and to some degree, or heat. So again, the more rheumatoids, the more autoimmunes are more on the heat side, damp heat. You know, the more common ones, the osteos, are generally more cold, wind, cold, damp. The rheumatoids are more a lot of like inflammation, disfigurement of the joints. That implies heat. That's more, you know, wind, damp, heat. Okay, so you've got to include points, and you can look these up in Machocha. I may have included some here. Machocha's got a lot written. You can go online. I mean, just TCM has a lot of like pretty standard wind, cold treatments. I've also included treatments for arthritis, I think, in here as well. You know, local points do really well here. Arthritic conditions, as well as like for the next one, chronic B obstructions, does really well here, local points. And liniments and plasters can do really well here as well. The hip is a big joint, so it's easy to apply plasters to. It's easier to make poultices and apply them. We're going to talk a little bit more about that later in the course. But generally, if the area feels warm to the touch and the person feels like they feel heat inside, or it's relieved by cold, with ice for less than 10 minutes, then that's a heat symptom. A lot of people say, oh yeah, it's much better with ice, but they're icing it for like 30 minutes and it just numbs it out. It just makes it numb. So that kind of overrides whether it's heat or cold, because honestly, if you put cold on a joint, on the hip joint or any other joint where there's cold stuck in the joint, it's going to feel worse for a few minutes, but then after about 10, 15 minutes, after it gets numb, then it'll feel better because it's numb, right? So when you are testing this out, this is something that I learned myself. It's not in any books. Like, you got to make sure that they're icing it for like 10 minutes or less. Otherwise, they're just numbing it and you won't know. But obviously, weather, you know, it's worse in cold weather. Oh, it's better in warm, you know, better in warmer weather. That's cold. Right? Cupping is great. Cupping is great. Perfuses the area with chi and blood. We all know chi is warming, blood is nourishing. So I do a lot of cupping. You can even do moving cupping with silicone cups over the area. You can put down like a warming oil or liniment and then do the cupping over that, either static or dynamic moving cupping. Really nice for the hip. The liniments, like I said, you know, have the patient apply them like 3-4 times a day. Again, you know, the hip is a deep joint. So if there's cold moxa on top of the needle that's inserted in maybe different areas of the joint, you know, like they find an osseous point and go in as deeply as you can, right? and then do moxa on the needles. You know, you don't have to just do one. I mean, you could do like a bunch, like 3 or so. I generally don't do more than 3 at a time, but that is so wonderful. You know, if you can, sometimes you just have them sit in a chair. I mean, if they can't lay down on their side, or if it's hard to get to laying down, you know, maybe an open-sided chair, but you can do this like in like gallbladder 30. You can do it in the motor points of the glute med, glute min. You can do this into Ashur points, right? I don't generally moxa needle trigger points. They seem to be extremely sensitive. So I often don't do that. If the motor point is extremely sensitive, you get a lot of fasciculation. I don't moxa needle that. Just needling it enough is fine. You can also, if you want, like maybe needle at the point, but just a little bit more shallowly into the muscle tissue, but in moxa needle that. But I really like to bring it into the joint. So you can get 3, even 6-inch needles, needle into that joint space, like around or behind the greater trochanter, and moxa on the needle is just so good, so nice, you know. And then you can like do cupping or do cupping first. Gallbladder 34 with liver 3, gallbladder 34 same side, gallbladder 40 same side, liver 3 opposite sides. Very nice combination for this. You can bleed the Jing wells if there's a lot of blood stasis. And by blood stasis, I mean there's going to be some sharp pains that figure prominently in the hip joint. Balance method points seem to do fairly well. Again, lateral aspect of the deltoid. There's also a point that I've listed here that I learned from Whitfield Reeves, which is called the extra point John Qua. This is on page 10B, extra point John Qua. It's located halfway between the greater trochanter and the ilium, and I needle it pretty deeply. It's about 2 to 4 sun posterior to the regular gallbladder 29, which is actually different than the gallbladder 29 I learned from Worsley. But that's all good. It's almost always sensitive. You can needle this pretty deeply, 2 to 3 inches. You know, even on a skinny person, it's a couple inches in there. You can moxa needle this point. And, you know, Whit said to, you know, he actually puts like a couple of needles in there. He doesn't just do one. He usually puts like a couple in there, a couple or 3. And that's a really nice point. So I want to back up. For osteoarthritis and bursitis of the hip, there's an interesting treatment you can do when the IT band either feels tight upon palpation or tests tight, and we'll take a break in a minute, is where you have the patient lie on their opposite side of the pain. So if they have pain on the right, I have them lay on their left so the right side is up and exposed. I'll do gallbladder 30, maybe a couple of Ashur points, and maybe some motor points around the greater trochanter for the glute med, glute min. And then what I do is then gallbladder 34, and then starting at the distal edge of the greater trochanter. So say the greater trochanter is like here, and their leg is extending this way, and here's their knee, right? They're laying on their side. So here's the greater trochanter, here's the knee and gallbladder 34. I'll do a point just distal to the greater trochanter, maybe like just to the point where they like feel it in the IT band, right? I'm going along the IT band, right? So I'm putting a point right where the IT band kind of comes into the greater trochanter, about a ½ an inch, right, or so. And then I'll palpate down towards gallbladder 32, right, which is obviously past, it's about halfway between, or about 1/4 of the way between gallbladder 31 and gallbladder 33, which is right at the knee crease. And towards that way, I'll palpate like every ½ inch or so, and I'll feel for any kind of Ashur points, and I'll put at least 3 needles somewhere like in that area. And if there's a lot of tension and spasming, or a lot of tightness, like they try to AB duct the leg and there's a lot of stiffness or tightness in the IT band, I'll do gallbladder 31 as well. So Worsley had gallbladder 31 in the IT band. I think Deadman has it just posterior to the IT band, I believe. And for gallbladder 31, I don't leave that in. The other ones I'll leave in for about 15, 20 minutes. And you can also include gallbladder 40 as well. So you've got them laying on their side, I'm doing gallbladder 30, maybe some Usher points, maybe with Moxa needle, maybe not, or motor points for the muscles around the hip, glute med, glute min, right? The TFL, the tensor fasciae lata. And then just distal to the greater trochanter, I'll put in a needle about 1/2 inch and then palpate along the IT band, right? Do a couple of points, gallbladder 34, gallbladder 40. And then I'll go back, and if that IT band is real tight, I'll needle gallbladder 31, do the circular needling technique, right? To draw that wind out, and then pull it out, and I leave it out, right? And that can be really, really nice treatment. Does that make sense? Right? Gallbladder 30, gallbladder 34, gallbladder 40, right? Go back, motor points, trigger points, and then the IT band points. And if the IT band is super tight, then I'll do the circular needling technique for gallbladder 31. And that's really nice. That clears a lot out. And you may or may want to include the Jingwell point at the end if you sense there's like a lot of like wind, cold, damp involvement, right? A lot of external pathogenic factor involvement. It's a nice way to move out. You've got all this chi moving, and then you kind of like vent out that EPF with the either like the bleeding or there's like the quick tonification of the Jingwell point.
I have a question time.
Yeah, we'll take a question and then we'll take a break.
So in the treatment you just described, the needle that is 2 to 4 cm posterior to the traditional gallbladder 29,
Yeah,
you're going at sort of like, typically the buttock has a curvature on the lateral
Yeah.
aspect. So I'm kind of looking at a diagram. So you'd be at the posterior edge of that kind of crease,
yeah,
going into the thickest part of the buttock.
yeah, yeah,
Okay, sort of like at an angle.
yes, yeah.
Okay.
And this is great for osteoarthritis and bursitis of the hip. This is great for osteoarthritis and bursitis of the hip. And that needle technique is most often predominantly applied to the bursitis, but can be used for, as they say in Baltimore, arthritis. I love being from Baltimore. It's such a quirky town. All right. So again, Legge on page 88 to 90 has got some nice points that they recommend for like cold and damp. I've included them here in number 12 on page 10, cold, bladder 23, stomach 36, bladder 23, the Liao points. You can also do the Liao points with Moxa on the needle, damp, list of points, wind, obviously the Jingwell points, any point with wind in the name, or bladder 58. Okay. And, if it's chronic, you got to move the blood. Moxa and needle on the AEPs, including bladder 17, really helpful. Blood moving points along those channels can be really helpful. She cleft, Luo points. Okay. And herbs can be really effective. All right. Let's take a break till 11:30. You guys good with that? It's 15 minutes. Do you need 15 minutes or 10 minutes? What do you want? 10 or 15?
I'm fine with 10.
All right. Let's do 10 and then we can probably finish early. All right. We'll come back at 25 after. So continuing with the hip, we're going to look at corrective exercise. Just a quick word. So on your class notes for today, what I have done is starting on page 11, or at least what's page 11 on my notes, I have folded back in the conditions from class 8 with the highlighted treatment lists. So hopefully you should see that. It should start on page 11, about 3/4 of the way down from class 8. It'll start with back strains, then it goes to back sprains, then it goes to herniated disc, possibly without sciatica, then SI, sacroiliac pain, okay, and it ends with that. And I've also given you a list of some resources at the very bottom of page 19, or towards the bottom of page 19, from like Physio Tutors and Quizlet and YouTube of Physio Tutors. So I've gone back and sort of filled in that. Remember, I left the treatments out from class 8. So I've gone and filled those back in and included them at the end of these notes. Does anyone not have them? Okay, good. Very good. All right. So again, my goal is to present to you a basic understanding about how to suspect, assess, and diagnose common hip and low back related conditions, how to discern between and among the different possible diagnoses, or at least to highlight or isolate what is primary in terms of a Western condition, how that translates in terms of Chinese medicine, ways of assessing it at a very granular level involving the different meridians that are involved, sinews and primaries, the different substances that are involved, possible external, internal pathogenic factors, focusing on the level and refining that using specific orthopedic evaluations and manual muscle tests. The manual muscle tests I'm still uploading, but you should have all of those soon. And this way, and then also giving you like specific treatments to choose from based on the results of your assessments. And then if one of those treatments doesn't work, you'll be able to kind of refine your diagnosis to rule out some things or to emphasize other things more. Okay? So that's my goal for you, is to kind of give you not just the formula for how to treat, but the formula for how to approach treatment and consider what to do when and why. Okay? Does that make sense? This means a lot to me, because this is something that like I never got. And even like with all of my continuing education, it kind of revolves around just one side of either assessment or just treatment, with not a lot of dot connecting and looking at how to discern various possibilities. Matt Callison's course did a lot of that, but there's a lot of emphasis on conditions that you'll probably not see unless you're working very specifically with pretty devoted athletes, right? So I would say about 75% of what he talks about in his wonderful, fantastic, excellent courses, but about 75% of that is going to be stuff that you won't commonly see unless you specialize in treating athletes, okay? So if you have the moolah, definitely take it. It's really worth it. All right. So, oh, there's something in the chat. Sorry, I clicked that down. I do hope to get into clinic. Yes, eventually we will get into clinic. All right. So let's go over some corrective exercises. I'm going to share my screen. So four down on module 9, you'll see corrective exercises, but you don't have to look at it right now. I'm going to pull this up for you by sharing my screen. So I've gone to the website. Oh, where is it? Okay. Yeah, here we go. All right. me a second here. All right, so there's two links. One is for anterior pelvic tilt, the other is for posterior pelvic tilt. I've also listed some exercises and some stretches that you can do, all right? So this wonderful website by Shana McQuilkie, she's a chiropractor. So she has this wonderful website called or I think maybe she was maybe contributing to this wonderful website called backintelligence.com. This was updated back in March. So she goes through, you know, what is an anterior pelvic tilt? This is what it looks like, you know, what causes it, right? And this is, again, this is meant for lay people, right? So you already know all this stuff, right? So you know how to find your PSIS and ASIS, right? We've gone through all the assessments and things like that, right? She even goes through the muscles again. The tightened, this would be like the locked short, and then the weakened would be like the locked long, okay? And then she gives you stretches and strengthening exercises. Again, what's locked short needs to be stretched. What's locked long, the weakened muscles, needs to be strengthened, okay? All right, so she gives you stretches first, right? Kneeling hip flexor, and then she tells you how to do it. And then she even gives you a video. And then there's the child's pose, right? She tells you how to do it, right? The cat-cow, right? Those of you who do yoga, you're probably familiar with these two, the child's pose and the cat-cow, right? And then she tells you how to do it. On this one, she also gives you a video. And then the warrior two pose, right? Then she tells you how to do it, right? And then the double knee to chest stretch, right? And she tells you how to do it. Then there's strengthening exercises. So there's planks, right? With the descriptions, glute bridges, right? Which are very helpful. When you're doing the glute bridge, when the patient brings their hips up off the floor into that bridge, they want to squeeze the gluteus muscles, right? Squeeze, right? Same with the squats. And you want to drive through the heels, so you're not putting the weight on the balls of your feet, but the weight on your heels, right? So how to do it, dead bug, right? This is a nice one, right? Alternating sides, right? Helps improve the core. And then the bird dog is really good. If people want, they can wear knee pads, or they can put something under them, like a really thick towel under their knees, because some folks have like a sore knees, right? And then she gives it like a little conclusion. And you can also email her. Here she is. She's actually Angelica Houston's sister, I think. Maybe not, but she just looks that way. But anyway, she's an interesting lady. She's up in Canada. All right, so that's a really nice one. And then there's also a second one for the posterior pelvic tilt, right? Now, I want you to look at something real quick here. So look at the way, and by the way, like I'm not looking at your faces, so can you all hear me or see the screen? Okay, all right.
Yes.
Yes.
Okay, great. So I want you to look at this posture, and I want you to compare it to this posture. And I want you to think about the mind, the state of the mind or spirit of the person with this posture and a person with this posture, right? Like, you know, clearly this is I mean, she's also got her hands on her hips, which also indicates something else as well. But even if her arms were like straight down at her sides, right? This is a person who's kind of like thrusting their pelvis forward. In fact, there is a condition called forward hip shifting, where like the whole pelvis is not just anteriorly tilted, but thrusting forward. And so that's, you know, that also implies a certain mindset, right? So this is obviously not somebody who's going to meet life passively, right? You look at this guy, right? He's like more concave, right? You know, this is going to be someone who's not going to be like, you know, asserting their power forward into the world, right? The way this one is. Like, so she's probably a little bit more type A. He's probably a little bit more type B. again, it's not like one is better than the other. There has to be balance, right? So we have to move forward in life with power and grace, but we also have to occasionally be receptive and flexible, right? So, this is kind of like they're probably going to burn up their kidney yin and yang faster than this guy, who's probably going to have like a more deficient lung yin, heart yin, lung qi, heart qi, right? Gabish? All right. So I want you to think about, like, when you're in the presence of your patient, how does their posture impress you? How does their posture strike you? Like, what's the emotion or emotions? And again, you always want to check this out. You don't want to jump to conclusions and then, and then base your decisions based on an unexplored conclusion, right? You want to treat it as a hypothesis. But I want you to begin looking at the patient's posture and considering how you feel in their presence when you tune into their posture. All right.
Time, is this in the blog section of that website?
Is it in the blog section?
Yeah, I was looking for this page on the website, and so it is in the blog. I see it.
Blog
Okay.
posture correction. Yes.
Thank you.
Yeah. If you're looking at the website, it's on the blog. It's on the
Thank
blog.
you.
You can click on blog and you can read up on that. Okay. Does that make sense? So this is something I want you to think about. And then if you have trouble finding these lists on the back of page 2 of corrective exercises, I'm happy to take maybe like pictures and upload them, but they are in this book, which I'm having trouble lifting with one hand. It's this book here. This is actually part of my exercise routine. I work out with the book. Right. So they're in that.
Just don't create an Akabani imbalance.
That's right. Yeah, I really should have, like, buy 2 of the books, then I can do both sides. So with just a few minutes, I wanted to mention a couple things. The dermatome pattern of nerve root issues is on the canvas. Long story short, if it loops around the side of the hip and goes down the front towards along the stomach channel, to the knee, that's generally the L4 nerve root. That means it's the nerve root coming from just below lumbar 4. And what happens is it kind of loops around anteriorly, goes down what is roughly the stomach channel. And then when it hits the knee, it often then goes into the medial section of the leg, sort of like the inner lower leg, like the inner calf. All right. The motor weakness is going to be the extension of the quads, right? So leg extension is going to be weak. I often have them try and do a squat, right? And that will often have a lot of trouble doing the squat with either pain or weakness. And then if you do reflex testing, if you hit the little rubber mallet just below their kneecap, just below their patella, the knee jerk will be much more diminished. All right. If the nerve root is coming out of L5, like between L5 and S1, that generally goes down the back and down the side of the leg, the whole side of the leg, upper and lower, along the gallbladder channel. That's generally L4. And they'll have a lot more trouble dorsiflecting their big toe or their foot, right? So when you have them stick their leg out and dorsiflect their foot or their big toe, they'll have a lot of trouble doing that. They'll also have a lot of trouble doing the heel walking, right? Remember we talked about that, the heel toe exercise, they'll have trouble doing the heel walking. S1 is generally going to be down the back of the glutes, glute max, down the posterior bladder channel. That's generally S1. They're going to have a lot more trouble with plantar flexion, right? Plantar flexion or dorsal extension, right? And that's going to give them a little bit more trouble walking on their toes, right? Because if you think about it, right, that's plantar flexion, right? Dorsal extension, right? They're coming up on their toes, right? So they're going to have trouble doing the toe walking. And then in terms of reflexes, the ankle jerk, like if you jerk along like around stomach 41 area, liver 4 area, there's going to be a diminished ankle jerk if you do those reflexes. Right? I just wanted to mention that. And I don't want to confuse you, but I just gave this to you to kind of introduce you to the idea of the planes. For some of you, this will be like, oh yeah, this makes perfect sense. For some of you, it's going to be really challenging. If it's really challenging, just skip it, put it away, maybe look at it a year later, you know, a year from now when you've done more treatments and you have a better understanding. But there's basically 3 planes, right? Because we operate in 3 dimensions. So there's what's called the frontal plane or the coronal plane. That's like if you took like a sheet and put it through like just anterior to do 20 and like my ears and went and just sort of sliced me in half to separate front and back, right? So the coronal or frontal plane goes this way, right? So it divides the body into front and back, right? Anterior and posterior. Then there's the sagittal plane, which also goes top to bottom and divides the body into left and right. That's called the sagittal plane, or sometimes called the lateral plane. That divides the body into left and right. Then there's what's called the axial plane or the transverse plane, which goes through the waist at the umbilicus in the front and do4 in the back. So right through the umbilicus, that separates the upper body from the lower body, okay? And so different activities are going to work in different planes, right? Running, right, breaks the coronal or frontal plane and is a sagittal plane exercise, right? I'm running, I'm going this way, my right arm and left leg go up, foot go up, then my left hand and right foot go up, right? I'm moving in this sagittal plane, but it breaks the coronal plane or the frontal plane, right? So you basically want to do exercises according to the planes. If you really want to like dive deep into the nitty gritty granular aspects of this, right? So postural deviations, right? Imbalances in the posture are defined by the plane that's broken or they move away from, right? And this is listed on page 2 of the exercises. This should be like the 4th dot or the 4th document listed in the class 9 module section, okay? So cervical lateral flexion, what plane does that break?
Sagittal plane.
Sagittal plane, right? John's going like this. That's the sagittal plane. So it breaks this plane. It goes along the coronal or frontal plane and it breaks, right, this plane. So your corrective exercises are going to be in the plane that is broken by the deviation, right? So if deviation means I have a problem with a certain exercise. So I'm going to be doing exercises in that plane that is broken by this movement. Okay? So transverse planes, right? The one that goes this way, the transverse plane are going to be treated with rotational exercises. Frontal plane deviations are going to be more abduction, adduction exercises, right? And then the sagittal plane deviations are going to be more like with flexion and extension, okay? To kind of to put it back into balance, all right? And I've given you some sort of like basic, just very basic sort of acupuncture that can be applied before the exercises using regular needles or during the patient doing exercises with those Pionex needles that are like, not ASP needles, right, because those are for the ears, but what are called Pionex needles. Have you ever seen these? These are on Lhasa. I think they're made by Sarin. And they're much more evolved than the ones that were created by Carbo, which made the worst needles on the planet. Don't mind my saying that. They were just like so painful. Sometimes you could pull one out and you could actually like see the barbs at the end of the needle. They were just like so nasty. They were so nasty, which is why they were so cheap. I think they've since gone out of business because they were just so awful. So anyway, maybe the earth swallowed their factory in a natural disaster. But anyway, Pionex needles are just so wonderful. So what you can do is and I tell the patient, like after I've corrected their posture, I say, this really isn't going to last. We need to do the new stretching or exercises, right? Or stretching or exercises and herbs, right? So one of the things you can do is you can put Pionex needles on the opening point of the 8 extraordinary vessel that's related to the type of exercise the patient will do. So I've given you just 3 bullet points there, one for Renmai Yin Chow, right? Because again, Renmai is opened by lung 7 and kept open, coupled point with kidney 6. So Yin Chow is the opposite or the complement of the Renmai. So it's opened by kidney 6 and the coupled point is lung 7. Or Chongmai Yinwei Mai, and this is for pain with flexion or adduction, right? So what you do is you have somebody do one of these exercises that involves flexion or adduction, moving towards the body, moving a limb towards the body. And what you would do is you would put an intradermal needle or even a regular needle. I mean, you just put like a regular needle in there if you want, like, and then have the patient repeat that exercise. And if they feel better, that's the one to do. So for example, like if they have pain with certain flexion, like hip flexion, right? Maybe I'll do a regular needle or a Pionex needle on the opening point for Renmai, which is lung 7. And then I'll have them repeat that hip flexion exercise, hip flexion movement. And if it's better, then I'm good to go. If it's not, then I try kidney 6, which is the opening point for the Yin Chow. And then I have them repeat that exercise. And if it's better, then there we go. That's the one, right? So if it's an adduction exercise, right, movement that like hurts them, then I might do the opening point of Chongmai spleen 4. And if that doesn't work, then the opening point of Yinwei Mai, which is pericardium 6. And if that makes it easier or less painful to do, then that's confirmation. So then I'll give them the Pionex needles to take home with, one to just leave in 3 to 5 days. And they can also massage that Pionex needle at the top a little bit before and during their exercises that they're doing to strengthen or stretch. Does this make sense? So this is just another way of like adding to the treatments. Again, yeah.
Do you find that if they have the Pionex needles in, does it become like a little tickler in their brain to actually engage in the exercises or the stretches?
Yes, it is a reminder. It is a reminder, and it's a very nice reminder too. So that's a great point. Thank you for bringing that up. So again, there's other exercises. Do Mai Yang Chow, right? Do Mai is spleen 3, coupled point bladder 62. Yang Chow is the opposite of that. Opens with bladder 62, coupled with small intestine 3. And then that's for pain with extension, right? Extension type pain, right? Or abduction, moving away from the body. And then the Dai Mai is obviously with rotation. Or Yangwei Mai, right? So Dai Mai is gallbladder 41, kept open by triple heater 5. Yangwei Mai is opening point, master point, triple heater 5, coupled point, gallbladder 41. The way I do these, the way I was taught by Matt Callison is you do not do them bilaterally unless you're working with the patient's body bilaterally. And you don't do like master point on one side, coupled point on the other side. You do them on the same side as the pain. So if I have trouble with right hip flexion, right, then I'm going to do lung 7 and or kidney 6 on the right, right? If I have trouble with like, rotation and it hurts, on the left, then I would do gallbladder 41 and or triple heater 5 on the left. Does this make sense? You don't have to worry about male, female, opposite sides. You don't have to deal with any of that. Right? It's simple. Same side. All right. So, like anything, I would recommend that you go, in your abundant spare time, you you practice some of these exercises. If you're having trouble finding them, let me know, and I'll maybe text you a picture from Callison's book. He's asked us not to really share a lot of his stuff, so I'm just asking you to honor that. I'm just giving you a little bit as a kind of a taster, so you can then have something to go by when you explore this, like on the interweb or other texts. Thankfully there's a lot more available now in terms of resources about, different exercises and things like that. But my goal is to help you put together a really comprehensive treatment strategy that involves proper assessment and diagnosis, a very granular, fine-tuned and refined treatment plan, or at least try things out. And if that doesn't work, then you know what next to go to, right? Combined with corrective exercises that include stretching for shortened, overactive muscles, or strengthening exercises for lengthened and inhibited muscles, right? And these treatments will involve sinew and primary meridians. They will involve dealing with external pathogenic factors. They will dealing with the substances. They will look at motor and trigger points, and again, other assessment techniques such as orthopedic evaluations and manual muscle tests, which I will get up on the YouTube channel, I promise. I'm a little behind on that. So, and then you can even based on, the nature of the movement that causes pain, you can look at either the plane or different exercises, or based on the postural imbalance, you could look at different exercises, and then you could support the efficacy of that. And we can only heal as fast as the body will heal, but you can help kind of maximize that by then applying Pionex needles onto points of the 8 extraordinary vessels that relate to that exercise that will help correct the imbalance, right? Does this make sense? I know it's a lot.
Quick question. Is the test is always, is it improved in the moment? Not, does it improve in 2 days after this treatment? Okay.
No, it should be like some degree of either decrease in pain or increased range of motion. Usually both. Now that may be just a little bit, some people may get a lot, but some people may just get a little bit. But if you're getting a little bit, a little bit is a good sign. And I tell my patients, a little better every day.
Okay, thank you.
Yeah. So it
Good
might,
time.
yeah. Yeah.
Now with using the Pionex, does that mean that you really do need your patient to be more aware of their body? Because if they're not really aware, how profound have you seen a difference with the use of the Pionex? Has it been a profound effect when you've used it, or can you say a little more about that?
Results may vary. So it depends on the patient. And I don't really worry so much about how aware they are of their body, because and I didn't get into this, and this is actually something that Matt Callison talks a lot about, and some other practitioners talk a lot more about, in terms of a deeper, finer physiological level of how muscles work and how the nervous system works, both in terms of proprioceptive as well as motoceptive. So one of the side effects of your treatments will be enhanced proprioception, which will be enhanced awareness of their body, right? We all know how to use our fingers, But then you go to learn how to try and play piano or guitar, and you're just like, what the hell? You know, like I thought I knew how to like work these things, right? You know, it's like you're creating different pathways which enhance your awareness, self-awareness, proprioception. The side effects of your treatments is going to be a greater body awareness by the patient. So I don't worry so much about how aware the patient is in their body. If they're not aware, I just say, go do this. This is why, and you'll feel better. And this is and how it fits into the treatment plan in terms of how they're going to get better. Right? This is going to extend the benefits of treatment. This is going to help heal the body, help the body to heal itself. This is going to help retrain muscle memory so that you're able to maintain a proper posture instead of falling back into these old habits which create dysfunction, imbalance, and pain, right? Now that's something I learned to say after, you know, practicing for 23 years. Like, again, you're going to like just fumble through it, but just say, make you better, right? You know, like some version of that.
Thank you.
You know, and the rest will take care of itself. I don't worry about how body aware the patient is. Yeah. So some people, it makes a profound difference, and some people it makes a very subtle difference. It really depends on a lot of factors, most of which is how padded, how much upholstery they're carrying around their waist, and their diet. You know, we eat a diet, a lot of, not you guys, but a lot of my patients eat a diet that basically fosters, and I mean this in a different way, fosters a like kind of dumbness, like a lack of clarity and awareness. It like the damp diet obtuns the senses. It dulls, it makes people like dull and unresponsive and unaware. It like clouds our sense. That's why everyone's getting more and more reactive. You know, it takes a lot of noise to penetrate this fog of damp, you know, that they're surrounding themselves with, and is fostered and accentuated by, you know, continued reactive, emotionally driven behavior. All right. So these are the patients that you're going to want to have them do some kind of like exercise or Qigong, probably not Qigong, they're going to get too bored, but I have them do like some kind of like pretty like intensive aerobic isometric exercise, you know, to help like kind of like wake them up a little bit. All right, so that's time. If you have any questions, by all means, feel free to text me or email me, and I will do my best to get this up onto the YouTube channel. And I hope you're all doing great. I know it's we're 9 of 14, so we're getting close, So, all right, y'all have a blessed day and a blessed week, and keep an eye out for like the discussion / assignment. Keep an eye out for that. All right, be well.
Next time.
Thank you, Time.